Okay, this is the second paper that I did is SOT protocol for analysis, adjustment, and assessment, and we studied 48 patients. We got some of the information on those 48 patients into this PowerPoint, but not all the information, but I'll go over it with you. I actually have one piece of paper right here I just want to grab. Yeah. Okay. Okay, the intent of this paper is to present SOT for analysis and adjustment and assessment for patients experiencing cervical pain and dysfunction. Okay. Again, I want to emphasize, I try to bring in two things here. And the second thing I wanted to do is to develop a method for analysis, adjustment, and assessment, and emphasize that word assessment, that we can assess the cervical problem well enough that in the initial visit, we can give the patient an idea of what their expectations should be, okay? And at the same time, be able to assess them at each adjustment and make sure, and monitor it, and make sure that we're on course, that the process is going along as expected. So that, again, we can communicate with the patient and let them know. I think the most comfortable feeling for me in dealing with a patient is being able to walk in the room and know we have both have the same expectations. So they have to know what I expect. So we want information, we want data on what we can achieve and accept them so that, because they're accepting what we can achieve for them and help them achieve. Inclusive of this non-randomized retrospective sequential review of patients' records at this chiropractic office. So we did review 48 patients and okay, here's some of the principles. Cervical spine-related problems and findings do not dictate the SOT category. So if I was asked the question right now, if a patient walked into your office and a lot of pain in their neck, couldn't turn their head, what category would they be? The answer is you don't know because you haven't identified a category yet. So you have to identify the category. Each of the three SOT categories is defined by SOT indicators, but each category allows for cervical analysis, adjustment, and assessment within its framework. So all three of them. I love that question that was asked before to Rich about, getting or should we be upper cervical adjusters? And, and Rich's answer was great. If once you change the way the cranium functions, you're changing head position and you're establishing. Last year I did a paper on the relationship of the three categories to the atlas, and all three of them, the atlas is reactive to what's going on in the category. So it's same principle here. What's going on in the cervical spine is part of a system, and you have to address the system. Each of the three categories is defined by SOT indicators, but each category allows for cervical analysis, adjustment, assessment. Dr. Desjarnett states, if you read the paper that I wrote on this, I'm a big fan of Dr. Desjarnett quotes, and I have a lot of them in here to support what we put in here. I think every time I read his book, and I've read him tons of times, I find new interesting commentary by Dr. Desjarnett. Dr. Desjarnett states SOT views the cervical column as part of the total and is responsible to which helps the total respond. Okay, so these 48 patients presented at this office, at my office. Yeah. Somehow that got messed up. 48% of this chiropractic spine. So there's a sentence missing in there. All of them had cervical problems. But here's an important fact. I eliminated people that were having acute episodal kind of reactions in their neck. All these 48 people had past histories, chronic histories of neck problems. I didn't want somebody coming in who was in a lot of pain. I wanted them to have it, at that time, and was in like a cervical and neck spasm. I wanted people to have a history here. So anyway, here's my category analysis here. I had 2 people that I classified as category 2. 32 is category 2. Did I say that right? 2 is category 1, 32 is category 2, and 14 is category 3. So even though category 2 was dominant, it doesn't mean that they might not be a category 1 or a category 3. Sitting cervical range of motion analysis, flexion, extension, right. We're going to talk about the clinical entities that we used here, but range of motion analysis is a big part of it, as is supine figure 8 and cervical stair step. And I tried to bring them together and see if they have a correlation, and I think they do. Now there's a number of patients that had various, of these 48 people, 27 had limitations in flexion, 6 in extension, 46 in rotation, 43 in lateral flexion. And none of them were, you know, horrible pain when you did it, but they had limitations. Of the 48 patients studied, improvement of range of motion function was noted in all 48. Each subject was adjusted at least 6 times within a 6-week period, 5 times within a 6-week period. That was our minimum. Of the 48, all but 3 reported a significant decrease of cervical pain and returned to ADL, activities of daily living, within a 6-week period. What's the number one thing that people with neck problems say, in my experience? You ask them,
I can't turn around to see
what's coming up on my left or right when I'm driving?
driving,
Yeah, right. So we always write on there their ADL, their activity. I don't like to ask patients, how are you feeling today? I try to use the word, take the feeling out of my dialogue, but I ask them, how you doing driving? I personally feel more comfortable asking them that question. And let them say, oh yeah, I can see cars coming up on my right now. Something like that. That's it. So report a significant decrease of cervical pain. We put together a chart, but I didn't get it on this. 5-degree increase in range of motion for rotation, there was 11. For 10 degrees of increased range of motion, there was 19. For 15 degrees, there was 8, 20 degrees, 6, one had 25 and one had 30. I would think the 25, 30 were more acute, but we tried to really put controls on that. SOT cervical techniques, stair step and figure 8, are designed to not only adjust the cervical spine, and it's an important point, but to continually analyze during adjustment. Desjarnett states that these particular cervical techniques combine analysis and corrections. So if you're doing figure 8 and stair step and somebody says to you, is this an adjustment? You say, yeah, but at the same time we're analyzing you. They say, are you just analyzing me? Yeah, but at the same time we're adjusting you. And that's one of the beauty things about all SOT. It's all dynamic process. Your head's constantly in it. Because if you lose your concentration on what you're doing, when do you pull the blocks out, blah, 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 yada, yada, yada. Patient seated with doctor standing behind him. What I did is just throw in another ingredient in this sitting range of motion testing. And I don't think it's so unusual, but it really works for me. You stand on the side opposite. I wish we had some extra time. I would like to show it, but on the side opposite, rotational limitation. In this example, right rotation, with the left hand turning the patient's face to the right with pressure with the right thumb on the patient's posterior right facet planes. And you feel for resistance. So I call it motion palpation. You feel these restrictions in the facet planes. Desjarnett felt that 95% of all cervical problems were disruptions in facet planes relationships. So continue down the cervical spine, feeling the most resistant level before repeating. A big one with us would be like, we would write it this as our finding. Right rotation 60 degrees, not 80, what it should be, at the C4, C5 level on the left. Okay? Now, here is the stair step in figure 8. You can read in the article, and there we have patients seated, we turn their head left and right, we see the limitations, lying down, left and right, we see their limitations, and then we do the stair-step technique and the figure eight. I've evolved to doing stair-step, lateral first, extension, figure eight, lateral first, which is ear to shoulder, then extension, which is the stair step, and then get into rotation. And I think you have to be really careful with rotation, especially in older people. And by the way, I must state, and I talked to Charles about this too, this study is not age sensitive, and it should be, but it isn't. So we have a mixture of ages in here, and age certainly is a factor in cervical function. But I don't have a lot of time here, according to Gary, so I won't get into the specifics, but they're great techniques. They're nonviolent, they're effective, and they're good to do. Just a couple comments here. Colette said neck and arm pain in his book, Neck and Arm Pain. I really like Calais' books. Not Colette, Calais. Irritated tissues must be ascertained as removable, reducible, and irreversible. And that's what we're talking about in the beginning. You have to be able to tell a person, we're going to get it really good for you. Reducible, we can certainly reduce the dysfunction and reduce the pain. Irreversible, we can't help you. Okay, which one do you think is most popular? And I think there's one that's very outstanding, most popular. Since we don't have a lot of time, it's reducible. I don't think there's any doubt in my mind. We can reduce it, totally move it. And I'm not talking about pain, I'm talking about function. Totally get it to every neck to work perfect. Well, I don't know. I'd say most everyone is reducible. A condition must be anatomically, this is another Calais thing, localized, mechanically, understood, and pathologically classified. I don't think we have, I think the methods that we're explaining here all do that. Between range of motion studies, that motion palpation, figure eight, and stair step, we get a good idea of where it's located, what's going on mechanically, and information. Here, this is pretty interesting from D.D. Palmer. I always like reading his book. I always am reading through things. And D.D. Palmer, the diagnosis of the act of recognizing disease from its symptoms, deciding as to its character, what lesions have occurred and will occur, how long it will endure, and what will be the probable outcome. Even D.D. Palmer agreed with us, or we agree with him, one of the two. But even D.D. Palmer said that you want to understand it and be able to communicate it and get an idea what you think the outcome will be. The bottom two were separated in translation here, but this is another interesting comment by D.D. Palmer that is relative. The medical man prescribes remedies for treatments of effect. The chiropractor adjusts the cause of derange function. And function's the word I like there most. Derange function. I always say the two most important words in chiropractic and SOT is systems and function. Conclusion, cervical analysis adjusting within the category system allows for a specific response to a specific cause, while the cervical responds to improved function of the system. Range of motion and motion palpation techniques allow for further analysis and assessment in the weight-bearing condition. Thank you very much. Okay. Okay, the intent of this paper is to present SOT for analysis and adjustment and assessment for patients experiencing cervical pain and dysfunction. Okay. Again, I want to emphasize, I try to bring in two things here. And the second thing I wanted to do is to develop a method. Okay, this is this second paper that I did is SOT protocol for analysis, adjustment, and assessment. And we studied 48 patients. we got some of the information on those 48 patients into this PowerPoint, but not all the information, but I'll go over it with you. I actually have one piece of paper right here I just want to grab. Yeah, we're on course. That the process is going along as expected, so that, again, we can communicate with the patient and let them know. I think the most comfortable feeling for me in dealing with a patient is being able to walk in the room and know we have both have the same expectations. So they have to know what I expect. So we want information, we want data on what we can achieve and accept them, so that, because they're accepting what we can achieve for them and help them achieve. Inclusive of this non-randomized retrospective sequential review of patients' records at this chiropractic office. So we did review 48 patients, and okay, here's some of the principles. Cervical spine related problems and findings do not dictate the SOT category. So if I was asked for analysis, adjustment, and assessment, and emphasize that word assessment, that we can assess the cervical problem well enough that in the initial visit, we can give the patient an idea of what their expectations should be, okay? And at the same time, be able to assess them at each adjustment and make sure, and monitor it, and make sure that we're